Hey everyone, we'll kick off in a minute. I'm just checking if everyone can see me on the video. I've turned it on, but I can't see myself. Yes, you can see me. Perfect. So it's only me that can't see me. Some can, some. Yes, you can see me. All right. So welcome in. It's great to have everybody online today for our Lunch and Learn session on reversible causes of arrest. So my name is Susie Helmish, for those that don't know me, and I am the Head of Education, come from a background of ICU nursing and resus coordination. And joining me on the chat today, moderating everything, is Jenny Brown, who also comes as one of our resuscitation educators and ICU clinician and educator in the past. We have opened up the chat and the Q&A today. So if you've got any direct questions, if you can put those into the Q&A, that just makes it easier to find them. It can get really busy on the chat when we've got a lot of people online. We've got a few hundred people online today. So if you can just put your questions into the Q&A, that would be great. And anything that we don't get to answer today, because it is a short session, we will answer in the community pages over the coming days. So we will get back to your questions if there's anything that gets missed. I would like to just acknowledge the traditional owners of the lands that I'm presenting from today. So I'm on Meanjin country, which is home of the Yagara and the Turrbal nations. I pay my respects to the elders past and present, and extend that respect to any First Nations people who are joining us today. So we are going to start the first session with a poll, just kicking it off. We will have a few polls throughout, and because of the sort of tight timeline of the session, there'll be only a short period of time for you to answer the polls, treating it a little bit like a resuscitation where everything is always super quick. So the first question is around what you think the priority of care is during resuscitation of a patient in cardiac arrest. And you've got three options there. Just as a reminder, if you sometimes can't see the polls, it does get hidden. I've just found myself now. I was hiding myself under the chat box. So just move things around if you need to so that you can see. You can also pop in your answers into the chat box if you can't access the polls. Okay, so we'll close those polls off and share those results. And most of you have answered really what the best answer is. It's a bit tricky with this one because there's a couple of best answers. And we know that sort of the three priorities that we've got listed down there are all shown to consistently improve patient outcomes during cardiac arrest. So the first priority is always going to be around giving high quality chest compressions with minimal interruptions. And so that means anytime we need to interrupt our compressions to do anything, whether it's a rhythm check or an intervention, we need to try to minimize that time. Our second priority is to focus on early defibrillation for patients in a shockable rhythm. So as soon as we can get a defibrillator onto a patient, we should, and then we need to be charging that up so that we can deliver that shock if they are in a shockable rhythm. The third priority is then focusing around identifying and treating the cause of arrest. So if we don't do that, particularly if we don't do that in a timely manner, then these patients will often stay in cardiac arrest or we won't be able to get them out. So we're trying to identify nice and early what's going on with them. So a good sort of process for us to be thinking about when we either arrive on the scene of a cardiac arrest is to first verify, do we have correct CPR happening, getting the defib on, charging it up and doing that rhythm analysis via coach with making that decision around if it's shockable or non-shockable. Then we do need to make sure that we've got IV access. So obviously on the non-shockable side, we would give adrenaline at this point, but shockable side, we're just going to prepare it to administer after the second shock. And then our final process will be around doing our patient assessment and treating for reversible causes. So while this webinar is on reversible causes, it is really important to consider where this fits in the ALS algorithm. Any assessment of reversible causes should be done around our planned rhythm checks, and every 2 minutes we should be charging up that defibrillator and then pausing compressions to analyse the rhythm. So this window also offers us the chance to perform some interventions, and we'll talk through some of those in a sec. However, we do need to make sure that we aren't causing excessive delays to recommencing CPR. And the diagram that is there is really just showing that process of charging up our defibrillator via coached, pausing to analyse the rhythm, and then making that decision if we're on the shockable or the non-shockable pathway. So this process, which is now done in most of our organisations around Australia, we obviously can only do it with a manual defib. It's not what we would do with an AED, and it has been shown to decrease the total time of the patient's chest, and that's what we're aiming to do. But what are we here for today? It's around our 4 H's and our 4 T's, so our reversible causes of arrest. If we can identify the cause, then that will help us to get ROSC for our patients and obviously help the ultimate survival of our patients. Some of our causes can be really time sensitive, so we do need to initiate rapid treatment. And if we aren't able to do that, then we can have a prolonged interval between the time of the arrest and ROSC. And this is the risk phase for our patients. So the longer that they stay in arrest, the less likely we are to get a positive outcome, and obviously the longer the risk of having poor perfusion and suffering from hypoxic brain injury. So we're really trying to improve their mortality and their morbidity risks. So our second poll is around some metrics, and I've thrown this in because it's still a really important part of not only our management of our patient and monitoring of sort of what we're doing, the resuscitation, but it's also what can it do or how can it help us with identifying our reversible causes. So again, I'll give you, got your 20 seconds. I was going to be really mean and just have 5 seconds like our rhythm checks, but I decided that wasn't long enough for people to actually click on. All right, so the majority of you have selected what is the best answer there, which is around end-tidal CO2 being able to measure the quality of our compressions and the adequacy of perfusion. Some of you have also indicated confirmation of ET placement, which it certainly does, but not too many of you have identified it being able to determine return of spontaneous circulation or to differentiate between true PEA and pseudo PEA. So our end-tidal CO2 can do all of those things. We know it's been long established that the accuracy of pulse checks is really poor, yet we still persist to do them. And what we need to start doing is actually using other measures to help to determine output as well as that confirmation of the quality of compressions. And end-tidal CO2 waveform capnography is a really important way of doing that. So if you're not currently doing that in your resuscitations, I suggest that you try to implement that as a strategy. Go and check, do you have that as part of your defibrillator? Do you have that as a separate monitor or part of your bedside monitoring if you're in a critical care environment? Well, our initial focus is going to be around establishing for shockable rhythms, early defibrillation. For our non-shockable rhythms, we really need to decide if we have got a PEA or a pseudo PEA. And obviously also asystole. So asystole sort of sits in its own basket. So if we've got asystole, we know that we don't have any cardiac output. There's no muscular movement of the heart, and we need to prioritise getting adrenaline into these patients and then our assessment for our reversible causes. For PEA, it's a little bit different. So what we're really trying to work out is this differentiation between true PEA and pseudo PEA. If you think about a patient who we have given adenosine to, and we have that long pause after we have adenosine, think about what's happening when we're giving adenosine. Does it actually stop the heart? And the answer to that is no. So we may see around 3 seconds of asystole, but that's a normal sort of pause time. So we don't generally stop that mechanical movement of our heart. Obviously, some patients, once we've given them adenosine, do stay in asystole, but generally speaking, it just really restarts our conduction system. So our pulse checks, which is our sort of resource that we use all the time, we know around 53% of the time we are inaccurate with those pulse checks. So we either feel them when there isn't a pulse or we don't feel one when there is a pulse. In shock or cardiac arrest, this is really likely to be worse with our ability to actually palpate a pulse. And so this is the reality. We know that it's difficult to feel a pulse in these sort of low perfusing states. So true PEA is truly a pulseless state with no cardiac output, whereas pseudo PDA, we may not be able to feel a pulse, but the patient does have an output. So these patients are in profound shock, hence why we can't palpate a pulse. But during CPR, for patients that are in pseudo PEA, it can actually be harmful to be doing CPR on these patients. So we've got to sort of think about how are we going to diagnose? Are they in true PEA or are they in pseudo PEA? Because we're wanting to optimize the filling of the heart. So for this to occur, we really need to now go beyond the algorithm and think, how can we apply this at the bedside? And this is where the tools such as our point of care ultrasound or POCUS is really helpful, as is our end-tidal CO2, our arterial lines. And now there's new data around our oxygen saturation probe, so just a regular oxygen sats. So you may not have access to point of care ultrasound, you may not have access to end-tidal CO2 waveform capnography or arterial lines, but you most likely do have access to an oxygen saturation. This is the waveform one that we're talking about. So all of these devices help to tell us about pressure and then perfusion. So what we should be starting to do is actually performing POCUS as a pulse check, because that's a more accurate way of determining perfusion when we don't have an arterial line in place. So that can be number one that we can do. Our oxygen saturation waveforms can also tell us some information about perfusion pressure, as does our end-tidal CO2. So our saturation waveforms, we're not expecting to get normal oxygen saturations in these patients, but we should actually see a normal trace. It may be slightly dampened because our perfusion pressures are lower, but we should still be getting a trace. So again, recommend that you go and do that in your resuscitations if you haven't been doing that already. When we talk about our end-tidal CO2, we really talk about getting a value that actually is that measurement of, do we have good quality perfusion? And so we're talking about an end-tidal CO2 of greater than 20. So if we are reaching sort of that 20 mark, that's an indication that our compressions are effective. Less than 10, it means that we've got either ineffective compressions or a problem like a pulmonary embolism. If we're seeing an end-tidal CO2 between 30 to 40, this is actually more indicative of pseudo-PEA. So for return of spontaneous circulation, we need to have a sustained increase of end-tidal CO2 above 45. So for a pseudo-PEA, think about, is my end-tidal CO2 between 30 to 40? And that may be what it's actually representing. So what we're seeing here is a heart that is actually still in motion rather than in complete standstill. Now, we could verify this by using our point of care ultrasound. So we'll talk more about our point of care ultrasound in a sec. And really what we're trying to do with these patients with pseudo-PEA, they've got a much better chance of survival. So even if we can't palpate a pulse, if we've got other signs, other indicators, we know that we've got a patient who is in profound shock, or there's a reason why their heart isn't able to actually contract adequately to restore perfusion. So that can really direct us to what we need to do to manage their reversible causes. So how do we determine what is the cause of cardiac arrest for our patient that is in front of us? Most of you are probably familiar with the 4Hs and 4Ts. Some of you may be really ace at remembering them, and some of you may always struggle to remember them. I know I've certainly attended an ALS course where I haven't passed because I couldn't remember one of the Ts. And I typically forget hypoxia, even though it's one of the most common one. If I'm rattling through my 4Hs and 4Ts, I do always struggle to bring one to mind. So if we're not using a cognitive aid and we're working in a really high stress environment of a resus where we have that high cognitive load, are we going to be able to remember our H's and T's? So the ABC approach to reversible causes may be a better way than the traditional H's and T's. And the reason for that is it actually focuses on what's important, which is our airway breathing and our circulation. So for each of our A, B, C, D, E, there's a simple question that we can ask that actually addresses all of our H's and T's. So if we start with our airway, and we should be doing this when we are actually assessing our basic life support anyway. So if we're starting with our airway, first question we should be asking is, do we have a secure airway? Is it patent? At this point, if we haven't done it already, we should be connecting our end-tidal CO2. And by doing that check, we'll know whether or not we've got hypoxia. So if we don't have a patent airway, our patient is 100% going to be hypoxic. The next thing we'll look at is breathing. So is there equal rise and fall of the chest? And then we can connect our oxygen saturation monitoring so that we can again get that waveform around perfusion. So if we aren't seeing rise and fall of our chest, then we know that we've got a tension pneumothorax. So we've now sort of ruled out or assessed 2 of our H's and T's. We then would move on to circulation. So can we see any signs of bleeding? Is there any fluid loss or fluid shifting that has occurred? So things like diarrhea and vomiting, sepsis, anaphylaxis. Have a look. Does this patient have a previous ECG? So were there ECG changes in the T wave indicating hyperkalemia or hypokalemia? Is there ECG changes that may suggest that this patient has had an MI? So again, with that history, those couple of questions, we can rule out 2 more H's and T's, so hypovolemia and our thrombus. The next point will be our D, or our diagnostics. So what diagnostics do we have access to or can we perform? So can we perform a point of care ultrasound? Can we perform a venous blood gas or an arterial blood gas? Can we perform a blood glucose? And so then we're ruling out our hypokalemia and our tamponades with our POCUS. And then our E is looking at things like envenomation or toxins. So we can also at this point expose our patients and get a temperature from them. So we're ruling out our final 2 H's and T's, toxins and hypo or hypothermia. So a really nice approach, and it's still prioritising our ventilation or oxygenation and our perfusion, which should be our priorities throughout any resuscitation. So that's a really useful tool to use to assess your patients. Every 2 minutes, we should be going back and rechecking those things. And that way we're having a shared mental model within the resuscitation team. So it keeps us all on the same page. It also means that if we have missed something or we haven't seen something in our assessment, somebody else in the team can actually contribute and point things out to us to help out. So point of care ultrasound, why am I banging on about it? Particularly me, for those of you that know me or have been to any of my courses, I'll always talk about how bad I am at reading ultrasounds. I can't make out any shapes at all. So I'm not the person that you want to do a point of care ultrasound during a cardiac arrest. And I think that's number one take-home message. We want to make sure that whoever is doing the point of care ultrasound is actually experienced at doing it. They need to know what they're doing. We are starting to see cardiac POCUS increasingly being used in resuscitations, particularly in the emergency departments and in the sort of pre-hospital care. So a lot of our paramedics, critical care paramedics are now carrying these devices as well. They're as small as your mobile phone, so they're really nice and sort of easy to cart around. They're also much cheaper than they used to be. So this is a really useful diagnostic tool. They've done a recent study in Canada called the SHOCK2 study, and this has been shown that the use of POCUS actually helps to identify the presence or the absence of a pulse in PA. So it's actually been shown to be more reliable than palpation of our carotid or femoral pulses. So there's 2 schools of thoughts around the use of POCUS during a cardiac arrest. So the first is that we go straight away to actually access one of the pulse points, and the femoral is usually recommended because it's a bit further away from where we're doing compressions. So we can actually use that to verify whether or not this patient has got profound shock and therefore a pulse or an output, or no output. If we are wanting to do it because we're now trying to assess our reversible causes, then we need to do this in this 4-step process. So step 1 is to prepare. So we have the probe and we place that onto the chest. This should be done during CPR while the defibrillator is charging. We then take a 10-second reading. So about 20 seconds out from the rhythm analysis, we'll put the probe into position. Then we'll record for the last 10 seconds as the defib is charging. And then simultaneously, so now everyone bar the person with the probe is not touching the patient. So yes, the probe still needs to be in contact with the patient while the rhythm analysis is occurring. But remember, we are predominantly doing this for patients who are in PA. And while with good quality CPR, we can definitely swap from PA to VT or VF, it doesn't happen very frequently. So the chance of us needing to defibrillate is much lower. And if we did need to defibrillate, so if we analyse the rhythm, we're going to be doing that much faster than a 10-second POCUS check. We would immediately then take off the probe, defibrillate, and then we would, while the team are getting back on the chest, put the probe back on to take the rest of the video. So we're not expecting people to be looking at what the probe is showing them during that 10-second time period. We're expecting them to record it. And then when CPR is restarted for the next 45 seconds, we can review what that recording was and then make our decision. And that leaves us then with about another 45 minutes to start the relevant treatment for what has been identified with the point-of-care ultrasound. So some of you may have seen this being used, particularly if you do work in EDs. Our ED doctors tend to get pretty excited about these devices and they've got access to them anyway. So if you've got a patient with PE arrest, have a suggestion to your doctors that perhaps they might like to do POCUS. And this is the process that they should be following. This infographic I will post onto the course page and in the community. So feel free to put that up on or near your machines or to share that in your units. So the diagnostic value of POCUS should be supported by appropriate management. And I think this is really key. Whenever we've identified a cause of arrest, whether that's via our POCUS or our ABCDE approach, we should be implementing a strategy to reverse any causes that we have identified. We don't want to be sort of going through all of our ABCDE or all of our H's and T's. If we've come across a cause, we actually want to start identifying that and start treating that. So we're going to go through a few case studies now for the rest of the presentation. So we'll work through a few of these and they've all got polls attached. So we're starting with Ron. So this is Ron, he's 69 years of age. He initially presented with chest pain and we have placed him on the defibrillator, charged it up, and we've seen this rhythm, which is our non-shockable rhythm. So we've disarmed to give adrenaline, and then we've got a bit of a history from Ron. So based on his history, we know that he's a type 1 diabetic. He suffers from hypertension and GORD. Our ABCDE approach shows that he's got a clear airway. He's got an oropharyngeal in situ, equal rise and fall with ventilations, and his end-tidal CO2 is sitting at 23. We can't see any signs of blood loss, and he does have a previous ECG which showed left bundle branch block. So his blood glucose is 1.5, no signs of rash or wounds, and hopefully you've all been madly answering the question about what you think the most likely cause of arrest is. And a few of you have put in what the most likely cause, and yes, there's a couple, as is fairly common for patients. We will often have patients who have more than one reason. So for Ron, we would be concerned about his blood glucose, and that's a fairly easy fix and treatment. So we would initiate that to start with our administration of glucose. We can either use our 50%, 25 grams, but if you don't have access to a central line, it is actually preferable to use 10% glucose. So for Ron, we'd be giving 250 mils of 10%, or we would give the 50 mils of the 50%, so the 25 grams. Our other concern, which again, most of you have indicated, is our risk of a thrombus. So we would be concerned largely that it is going to be a coronary or an MI thrombus based on his history. So the treatment for this is dependent on where we are. So today, because I'm in Brisbane, I would be transferring him to the closest hospital, which for me is the Wesley Hospital, and they've got a cath lab. So getting him to PCI is going to be the priority. If you don't have access to PCI, so if your cath lab is 90 minutes away, then we would start fibrinolysis on him and then transfer him as soon as we can. So alteplase is what we would administer for that. So that's our first patient, Ron, and it looks like most of you answered correctly with the most likely cause of arrest. We would still be wanting to check and make sure that we've got things like 100% oxygen going, because any arrested patient has got that risk of hypoxia. It just may not be the specific cause of arrest. It's unlikely that he's hypovolemic, but it would depend a little bit around how long he has been unwell for and if he's been eating or drinking regularly, but there's no other sign, so we wouldn't be thinking that as a primary cause of arrest. So our next patient is Gail. So Gail has presented, she's 71 years of age. She initially had palpitations and then became unresponsive. We started CPR, attached the defibrillator, and we have identified VF as a cause of arrest. So we have defibrillated her at 200 joules. And after we have done that, our priorities are to restart CPR and then to prepare adrenaline to administer after the next shock. So our history of Gail reveals that she suffers from COPD and congestive cardiac failure. She also has chronic back pain and has recently been commenced on oxycodone, and she's currently quite drowsy. She initially vomited, so we suctioned out her airway. She does have equal rise and fall with ventilations. End-tidal CO2 is 28. Cap refills 5 seconds. Blood glucose is 4.5. Pupils are equal and reactive to light but pinpoint, and we can't see any signs of wounds or a rash. So her most likely cause, and we've got a real split here going on. So again, there's a couple of priorities that we would be concerned with, and if we're going with our ABCD, the fact that she's vomited does mean that she potentially had a compromised airway. We've now suctioned it though, so hopefully that means that the airway is clear. We've got equal rise and fall of the chest, so we know that she's effectively ventilating. Our biggest concern is her level of drowsiness before arrest and the fact that her pupils are a pinpoint. So her reversible cause that we would want to treat straight away is toxins, and we would want to reverse the oxycodone. So administration of naloxone would be recommended. At the same time, there's significant risk there of hypoxemia. So we would want to verify that we've got 100% oxygen connected, and we could consider putting in a tube. So she may or may not need to be intubated, and we're not covering who and why we should or shouldn't be intubating today. So that's for another discussion. So Gail actually fits into one of our special circumstances. So as well as our H's and T's, we do have a number of special circumstances where we need to do things slightly differently. So our opioid overdose is now seen because of the opioid crisis that if we have got patients who are exhibiting any sort of signs, whether that's a decrease in level of consciousness or a decrease respiratory rate, or they've had potential exposure, that we should be administering naloxone. Pre-arrest, or if you don't have access to IV intranasal, is considered okay. Otherwise, we would administer a 400 microgram dose of naloxone initially. It can be repeated every minute, and we need to be titrating this. So naloxone has a very short half-life, which means that we would need to be monitoring these patients really closely because of the risk of them re-arresting or having a second respiratory arrest just due to that narcosis. So that's one of our first special circumstances. Our next patient is Jason. So Jason is 48 years of age, and he presented following a motor vehicle accident. He had a crush injury. He was actually pinned under a quad bike for about 4 hours. He had loss of consciousness at the scene and suspected fractured pelvis and rhabdomyolysis. So when we've connected him to the monitor, this is what we're seeing. So this is a classic PEA. So what we are seeing here is what looks like a widened QRS and weird looking T wave. So that's kind of your hint. Now, because he is a trauma patient, there's a few things that we might need to consider, and I'll talk through that in a sec. But to start with, we're going to treat what we've got in front of us, which is a hyperkalemia, particularly because he was initially responsive. So management of our hypovolemia and hyperkalemia is going to be really important. So what we want to do is to start some fluids to start with, which will be normal saline until we can get access to appropriate blood products. We would need to treat his hyperkalemia. So calcium chloride, 10 mils of 10% or 30 mils of calcium gluconate is a little bit more stabler and nicer on your veins if you've got access to it. So this is given to stabilize the cardiac membranes. It does not treat the hyperkalemia. So at the same time, we would be wanting to administer 10 units of Act Rapid or Nova Rapid, and then the 25 grams of glucose. So we are wanting to try to push that potassium back into the cells. So there are kind of more simple reversible causes for Jason, but he does fit into the special criteria of trauma. So our trauma patients are really quite different. So if they have arrested because of the trauma, and that needs to be established, so we don't do this protocol for patients who have had a medical event and then a trauma. It's only patients who have arrested from the trauma. So in this group of patients, we'll actually delay CPR until we can control the bleeding, relieve a tension pneumothorax if they have one, and manage their cardiac tamponade if they have one. So priorities in this group is actually going to be to do a point of care ultrasound as soon as we can to help with the diagnosis of the tension pneumothorax and the cardiac tamponade. Now, we saw equal rise and fall of the chest with Jason, so we could rule that one out straight away. We did have a bleeding issue. He was hypovolemic, so we would want to control that bleeding. Initially, that can be done with our crystalloid, so normal saline or Hartmann's at 20 mils per kilo. Otherwise, we would be moving to our blood products. So ideally, we would use fresh whole blood, O-neg, if that's all we have access to. Otherwise, the 1-to-1-to-1, so platelets, FFP and blood. We should also make sure that we are controlling and stopping the bleeding and then giving our tranexamic acid to help manage that. So trauma is a special circumstance, so we've got to think different things to do to actually manage that. So our next patient is Jo, and Jo's a 29-year-old who presented with pain on inspiration. We've connected her to the monitor, and that shows a very slow, unhappy looking rhythm, so non-shockable, which we have disarmed. We've also noted that Jo is actually pregnant, so she's about 24 weeks pregnant. So we don't make any changes to what we do from an ALS point of view, but we do need to change what we're doing from a CPR point of view. We would need to do manual displacement of her uterus to ensure that we're actually getting adequate perfusion. So her history tells us that she's normally quite sedentary. She's had a recent return flight from London. We have attached end-tidal CO2 to her, which is only reading at 15. We've got equal rise and fall of her chest. CAP refills 5 seconds, and she's also got a purple mottled chest. So I think we need the next poll for this one. So see if you can work out the most likely reversible cause, and then we have to think about how we are going to treat that. So with our pregnant patients, they can have different causes of arrest, and they can have the normal causes of arrest, and treatment is still going to be the same. So our priority is to actually save the mother first, but we need to be prepared to do an early Caesar if they fit in that criteria. So management of her most likely cause of arrest, which is thrombosis, is going to be administration of our fibrinolytic agent, so alteplase or tenecteplase, whatever you have. 50 milligrams is the recommended dose for resus setting for alteplase. Once we've administered fibrinolysis, we do need to be prepared to do at least 90 minutes of CPR, and that's to allow that time for that drug to work. We also need to be concerned because her end-tidal CO2 is quite low, and there's going to be a risk of hypoxia. So early intubation is important. But when we are talking about our obstetric patients, there are a few changes. So we should be calling for expert help, and this is our obstetrician team, and it is also our neonatal resus team. We need to do that manual displacement of the uterus, so not doing pelvic tilt, manual displacement. Pelvic tilt means that we can't do effective compression, so that's why we do manual displacement. IV access should be attained above the diaphragm. We should be anticipating a difficult airway, so we're able to get the video laryngoscope and the bougie. And then we do need to be prepared to do a C-section if there's no return of spontaneous circulation within 4 minutes. And our final case study that we are going to do today is for Ron. So Ron has come into us following a fall at home. CPR is in progress. His monitor shows that rhythm, which is a fairly typical, straightforward VT. So we have shocked him. We've prepared adrenaline for our next rhythm check, and we need to get his history. So we know that he's had a fall with a head injury, and he's just come out of the CT scanner. He had CT of his head with contrast 5 minutes ago. His baseline history is ischemic heart disease. He's treated with sotalol and a statin for that. His airway is patent. His breathing, he's got central cyanosis and a wheeze is noted. He's quite flushed. Blood glucose is normal, and we've got an extensive rash appearing. So our concern at this stage for Ron is going to be around toxins and hypovolemia. So our most likely cause of arrest for Ron is actually anaphylaxis. And one of our priorities with anaphylaxis is to give adrenaline. So despite the fact that Ron is on the shockable side of the algorithm, we want to give adrenaline first, and we're giving that to treat the anaphylaxis. So there's a couple of different guidelines out there around anaphylaxis. This is the ANSCA guidelines. It's our most updated guideline. And even though it does talk specifics for the perioperative environment, it does follow what our ILCOR guidelines are. So we want early IV adrenaline once they have arrested. We need to consider fluid resuscitation straight away, so 20 mils per kilo of normal saline. We should be commencing an adrenaline infusion after the second or third dose of adrenaline if it hasn't worked. And we also need to be considering glucagon. So for Ron, particularly because he's on sotalol, a beta blocker, we would need to be administering glucagon because it's less likely that the adrenaline is actually going to work. So that would need to be administered. So I know that I have run out of time. I just wanted to just cover one of the last special circumstances, which is around cardiac surgery. So this is, again, a multiple sort of reversible cause, but it's where we do something different. So for these patients, again, like our trauma patients, we're actually delaying CPR for up to a minute. And that's because CPR in this group can be harmful, and generally they're in tamponade, so they don't have any sort of blood to push around. So initially we will do a rhythm analysis. If it's shockable, we will give 3 stacked shocks. If it's asystole and they've got pacing wires, we will connect them to the pacing, their external pacing. So we'll do DDD via epicardial pacing. If they are being paced and they're in a PEA, we need to turn their pacing off just to check their underlying rhythm in case it's an underlying VF. Once we've done those things, so we've got up to a minute to do those. Once we've done them, if we don't have any output, then we need to start CPR and prepare for a reopen to facilitate internal cardiac compressions and internal defibrillation if they're on the shockable side. We should not give adrenaline to these patients. So adrenaline is actually withheld on this group of patients. If they're on a balloon pump, we keep that going, but we need to change it to pressure triggering, and it will obviously require adequate compressions to then work. So for this situation, it's a special circumstance. We would declare that we've got cardiac surgery or a CAL situation. So all of our special circumstances, whether it's opioid toxicity, our anaphylaxis, cardiac surgery or trauma, we should be making that statement. And again, that's our shared mental model within the team. So that brings us to the end of another very fast lunch and learn. So take-home points is always remember that our priority is effective CPR. So we want to make sure that we've got those physiological measurements with our end-tidal CO2, our SATs, and our arterial blood pressure if we've got access to it. We should be making sure that we are doing our resus reset. So that's around our coached every 2 minutes. It's a really good way of bringing us all back in line and restarting after we've done that rhythm analysis with our ABCDE approach. Utilising your ABCD approach to help you work out the reversible causes. It's just a really nice way. It helps us to focus on airway breathing circulation. Consider the use of point-of-care ultrasound, so particularly to diagnose our true PEA from our pseudo PEA. And the aim with our point-of-care ultrasound is to plan, pause, review, and intervene. And then finally, using your cognitive aids to help you to remember your H's and your T's. One of the things that you can maybe take home or give a try in your clinical practice is having a nurse to actually lead the code, and that enables the doctor to perform those assessments, and particularly with your point of care ultrasound. So have a think about the way that you manage your teams in your resuscitations in your hospitals. Can you utilise any of those strategies? So can you put any of those things in place? And I can see that Jenny has answered all of those questions. I will check them all at the end as well, just in case there's anything that we want to add into the community. But thank you all, everybody, for your attention for this webinar. And there's the link that has just gone in to review the actual evaluation. So to get your CPD certificate from today, you just need to complete the evaluation and the feedback, and then your certificate will be there. It should be available in the next hour or two. Sometimes it just takes a little bit of time for Zoom to sort of come across to say that you were actually here. The recording of this webinar will be available for you to watch on demand. So if you want to redo anything or slow any little bits down or just recapture any of the points, you're able to do that. So thanks everybody for your time. Hopefully I'll see you at our next Lunch and Learn. And in the meantime, I'll just show you a video as you're all going out the room, just to update you on how you can utilise our CPD tracker to keep tabs on your CPD as we sort of go into the new registration year. So thanks everybody. And thanks to Jenny, Abby and Georgia in the background for their help today.